200,000 people. That's roughly the population of Salt Lake City.
Yeah, that's a lot of people.
And every single year, that represents the number of people in the U.S. getting hit with acute cholecystitis. So, I mean, it is incredibly common.
It is. It's really a bread and butter diagnosis. If you work in an ER or a radiology suite, you see this constantly. Or at least, you think you see it.
Right, and that's the catch right there, because you'd assume with numbers that high, we'd have the diagnosis down to an absolute science.
You would think so. A simple flowchart.
Exactly. But the research we are looking at today, which is a comprehensive review from Stanford University published in Radiographics, it actually suggests we are missing the mark way more often than we'd like to admit.
We really are. The reality is that acute cholecystitis is a bit of a chameleon.
How so?
Well, the symptoms overlap with pancreatitis, hepatitis, peptic ulcers. Practically anything in the upper abdomen can look like this. And the tools we've been using to sort that out, what the authors call the old paradigm, are surprisingly subjective.
Subjective is a polite way of putting it. We're going to get into that old paradigm today. Specifically, why relying on a patient yelping in pain when you poke them is maybe not the best scientific method.
Yeah, the poke test has its flaws.
Right. But the core mission of this deep dive is to explore the new paradigm. We are looking at moving away from poking and hoving and moving toward using hard physics, fluid dynamics, and objective measurements to actually track the disease.
Exactly. We're shifting from a subjective art to an objective science. But before we get to the velocity of blood flow and tensile strength, we really have to start with the biology.
The underlying mechanics.
Because if you don't understand why the gallbladder is failing, the ultrasound screen just looks like static.
That makes sense. So let's clear up the definitions first for everyone listening. I think a lot of people, myself included, tend to lump biliary colic and acute cholecystitis into the exact same bucket.
Oh, absolutely. Just degrees of a bad stomachache.
Right. But the authors make a very hard distinction here.
It's a critical distinction to make. Biliary colic is essentially a plumbing issue. You have a stone, it gets stuck in the cystic duct, and the gallbladder spasms against it trying to push it out.
And I imagine that hurts like hell.
It does. But, and this is the key thing for you to remember, it's transient. The stone rolls away, the duct opens back up, and within 4 to 6 hours, the physiology returns to normal.
Okay, so colic is a temporary blockage. There's no permanent damage done to the organ.
Right. Acute cholecystitis, though, is entirely different. The obstruction persists, and that triggers what the Stanford team calls the double insult.
The double insult. That sounds like a bad breakup or something.
It's much worse than that. It's mechanical and chemical warfare on your own organ.
Walk us through it.
The first insult is the obvious one, the mechanical pressure. The blockage causes massive internal pressure because the bile has nowhere to go.
So the organ is inflating like a balloon.
Exactly. It's distending, it's stretching the wall, and as it stretches, it pinches off the tiny blood vessels that supply the wall itself.
Which causes ischemia.
Yes. Starving the tissue of oxygen.
Okay, so that's insult number one, the pressure and the ischemia. What's the second part?
The second insult is the one people often forget. It's chemical. The bile trapped inside the gallbladder actually starts to change.
Change how?
Well, the mucosal phospholipases, which are the enzymes lining the wall, they start hydrolyzing lecithins in the bile into toxic lysolecithins.
Okay, hold on. Hydrolyzing lecithins. In plain English, are you saying the bile is turning into poison?
Effectively, yes. Think about what bile does. It's a detergent. It's meant to break down fats in the food you eat.
Right.
But when that protective mucus layer in the gallbladder is disrupted by those toxins, the bile starts acting like a detergent on the gallbladder wall itself.
Oh, wow. So it's digesting itself.
It starts stripping away its own lining. Yes.
So you have this high pressure strangling the blood supply on the outside, while the contents are chemically eating the walls on the inside.
Precisely. That is the true pathophysiology. And once you understand that, pressure plus ischemia plus tissue breakdown, the new ultrasound signs we're going to talk about make perfect sense.
Because we aren't just looking for stones anymore. We are looking for the evidence of that specific destruction.
Exactly.
Speaking of stones, let's tackle that old paradigm quickly, because the classic teaching, as I understand it, is pretty straightforward. Step 1, you find gallstones. Step 2, you push on the gallbladder with the probe to see if it hurts, which is the sonographic Murphy sign. And step 3, you check if the wall is thick.
That's what generations of radiologists were taught.
So why are the Stanford authors throwing this out?
Well, let's look at the first step, what they call the gallstone fallacy. 10 to 15% of the adult Western population has gallstones walking around right now.
Wait, really? Just totally asymptomatic.
Completely asymptomatic.
So finding a stone is like finding a penny on the sidewalk. It doesn't actually mean much.
It means the patient has stones, sure, but it does not prove the stones are causing the pain. They could just be innocent bystanders while the patient actually has, say, a perforated ulcer.
Or pancreatitis.
Exactly. And then you have the Murphy sign, the poke test.
Right. If it hurts when you push on it, it's sick.
It is the absolute definition of subjective. The sensitivity in some studies is as low as 33%.
33%. That's worse than a coin flip.
Much worse. Think about who actually gets this disease. It's often elderly patients or diabetics, and those populations frequently have neuropathy.
Blunted pain perception.
Right. Or think about the context of the ER. The patient comes in screaming in pain, they get pumped full of morphine.
And then the radiologist comes in to push on them.
Exactly. They aren't going to flinch when you push because they're on painkillers.
Or, and this is the really scary part, if the disease is really bad, they might not feel it either, right?
That is the most dangerous scenario by far. If the gallbladder is gangrenous, meaning the tissue is literally dead, the nerves are dead too.
So they feel nothing.
You can push all you want, the patient won't feel a thing. So the Murphy sign fails exactly when you need it the most.
That is terrifying. You get a negative test, so you think they're fine, but the patient is actually dying.
It happens.
Yeah.
And as for that third step, wall thickening. That's often just edema, heart failure, kidney issues, liver disease. They all cause fluid to build up and the wall to thicken.
So it's just nonspecific.
Highly nonspecific.
Yeah.
So we desperately need better tools.
Enter the new paradigm. The authors of the paper break this down into 3 objective categories for you to look for: pressure, hemodynamics, and tissue changes.
Right.
Let's start with pressure. We know the first insult is that high mechanical pressure. How do we actually see that on an ultrasound?
Well, it's not just about raw size, although there is a really helpful exclusion rule they mention, the non-distended rule.
Which is?
If the gallbladder width is less than 2.2 centimeters, you can confidently exclude acute cholecystitis.
Because if it were blocked, it would absolutely have to be swollen.
Generally, yes. I mean, unless it has already burst, which we will get to later. But assuming it's intact, it has to be distended.
Are there specific size cutoffs?
The Tokyo guidelines have thresholds greater than 8 centimeters long or greater than 4 centimeters wide. But honestly, the real high-value sign here isn't a measurement. It's the tensile fundus sign.
Tensile fundus. It sounds like we're talking about bridge architecture.
We basically are. The fundus is the bottom rounded part of the gallbladder. Normally, if you push the ultrasound probe into the belly, a healthy gallbladder is soft. It deforms.
Like pushing on a water balloon that isn't quite full. It has some give.
Perfect analogy. Yes, it has give. But in acute cholecystitis, that internal pressure is skyrocketing. So the fundus becomes totally rigid.
Like a high-pressure car tire.
Exactly. It doesn't flatten when you push on it. In fact, it's so tense that it actually pushes back, bulging the anterior abdominal wall outward.
So the radiologist isn't just looking at the screen. They are physically feeling the resistance through the probe.
It's a visual confirmation of a physical property.
Yeah.
You literally see the abdominal wall bowing out on the screen because the gallbladder refuses to yield.
That is wild.
And that sign alone has a 96% specificity. If you see that rigid, bullying fundus, you are dealing with a high-pressure obstruction.
That feels so much more reliable than just asking, does it hurt?
It's completely objective.
Okay, let's move to the second category, which really seems to be the heavy hitter of this paper. Hemodynamics. Blood flow.
This is where we separate the amateurs from the pros.
Oh, bold statement. Why is that?
Because inflammation requires blood. The body's trying to flood the area with immune cells to fight off that chemical insult we talked about earlier. So we look for hyperpremia, which just means increased blood flow.
But the liver is right there next to it, and the liver is basically just a giant sponge of blood. Doesn't that get confusing on an ultrasound?
It really does. You can measure the velocity of the hepatic artery, the main supply to the liver. And if it's flowing at over 100 centimeters per second, that correlates with cholecystitis.
But I'm guessing there's a catch.
A big one. Liver disease, cirrhosis, or honestly just having a big meal can also spike that hepatic velocity.
So it's a hint, but it's not a smoking gun.
Right. The actual smoking gun is the cystic artery.
The dedicated supply line.
Correct. The cystic artery supplies only the gallbladder, nothing else. So if that specific artery is going haywire, you know for a fact the problem is in the gallbladder, not the liver.
Okay, but I have to play devil's advocate here for a second. I've seen ultrasound images. They are grainy, black and white snowstorms. And the cystic artery is what, a millimeter thick?
Barely.
Right. So is it actually practical to expect an ultrasound tech in a chaotic, busy ER to find this tiny thread of an artery?
That is the million-dollar question. And you're right, it is difficult. It requires significant technical skill. You can't just slap the probe on the belly and see it.
So how do they do it?
You have to lower the velocity scale on the machine, the PRF, because the flow is much slower than something like the aorta. And you have to actively hunt for it along the anterior wall of the gallbladder or at the neck.
And if the patient is obese or they have a lot of bowel gas?
It becomes incredibly hard. I won't sugarcoat that. It takes time.
Yeah.
But the Stanford team argues that the payoff is absolutely worth the effort, because if you can get a fix on it, the data you get is undeniable.
What's the magic number they are looking for?
40 centimeters per second.
That's the hard cutoff.
That is the line in the sand. If the peak systolic velocity, the PSV, is greater than 40 centimeters per second, it has a 92% positive predictive value for acute cholecystitis.
Wow, 92%.
It's huge. That tiny artery is just screaming, pumping blood as fast as it possibly can to try and save the dying tissue.
That's fascinating. So you aren't asking the patient how they feel. You are physically measuring the velocity of the body's own rescue effort.
Exactly. And if it's borderline, say, between 30 and 40 centimeters per second, that's the gray zone. You can't completely hang your hat on it. But anything over 40 is objective proof of severe inflammation.
Okay, so we have pressure looking for that tensile fundus, and we have flow finding a cystic artery velocity over 40. The third pillar of this new paradigm is tissue changes. This goes back to that chemical insult we discussed, right? The bile eating the wall.
Yes. And what does that actually look like? We look at two main things, the fat and the lining. Let's start with the fat, specifically echogenic pericholecystic fat.
Break that down for us. Echogenic means it's showing up bright white on the ultrasound screen, right?
Yes. Normally, the fat around your organs is dark or gray on an ultrasound, very similar to the fat under your skin. But when inflammation gets severe, it becomes transmural.
Meaning it breaches the gallbladder wall.
Exactly. It spreads through the wall and spills into the surrounding fat tissue.
So it's basically leaking inflammation.
In a sense, yes. And the physics of why we can see it is really interesting. The inflammation creates edema, which is fluid in the fat. So now you have all these microscopic interfaces between the water from the swelling and the lipid cells of the fat.
And ultrasound waves bounce off those interfaces.
Like crazy. That massive scattering of sound waves is exactly what makes the fat look bright white on the screen.
So if you see a glowing white halo around the gallbladder, that means the containment has failed, the wall is compromised.
It strongly implies the inflammation is aggressive and spreading. And that leads us right to the lining itself, the mucosa.
What are we looking for there?
Well, in a healthy gallbladder, you see this crisp, bright line representing the inner wall.
And in a sick one?
That line just disappears. We call it the loss of mucosal sonor afflectivity.
The line completely vanishes.
It gets very fuzzy, or it drops out completely. And this is a direct, visible sign of that double insult causing necrosis. The tissue is literally dying. The microscopic structure is breaking down.
That sounds really bad.
It is. If you don't see that crisp white line, you should be very worried about gangrene.
And what about sludge? I always hear about gallbladder sludge.
Sludge is interesting. It's super common in ICU patients just from lying there.
Mm-hmm.
But if you see thick sludge in an otherwise healthy outpatient who comes in with pain, it's a strong indicator of gallbladder dysfunction. It's a piece of the puzzle.
Got it. Now, you mentioned gangrene a second ago, which brings us to the danger zone section of the paper. They spent a lot of time on complications, gangrene and perforation. And honestly, I was shocked by the stats here. I thought gangrenous cholecystitis was a super rare worst-case scenario.
It is not rare at all. Up to 39% of acute cholecystitis cases are gangrenous.
39%, that's almost 4 out of 10 cases.
It is massive. And remember, these patients often do not have the Murphy sign because their nerves are dead.
Right.
So if you miss this because they didn't say ouch, the mortality rate skyrockets. They can go into sepsis very quickly.
And gangrene naturally leads to perforation. The dead wall just bursts.
Yes.
The authors actually bring up Laplace's law here to explain where it bursts. Now, I love a good physics equation, but walk us through why this matters in the ER.
It's brilliant. The equation is T equals P times R divided by 2. Tension equals pressure times radius divided by 2.
Okay, so tension is tied directly to the radius.
Directly proportional. That means for any given pressure inside that balloon, the part with the widest radius is under the absolute most tension.
Which would be the fundus, that bulbous bottom part we talked about earlier.
Exactly. The neck of the gallbladder is narrow, so the tension there is low. The fundus is wide, so the tension is maximal.
That makes perfect sense.
That is exactly why the fundus is almost always the site of perforation. It's simple physics. Plus, it's the furthest point from the cystic artery, so it gets the least amount of blood flow to begin with. It is the perfect storm for a blowout.
So let's paint a picture for the listener. You're in the ER, you have a patient who looks septic, they have a high fever, their white blood cell count is through the roof, they just look terrible.
Right.
You put the ultrasound probe on their belly, fully expecting to see this giant, angry, distended gallbladder under high pressure. But instead, you see a small, deflated one.
And that right there is the trap. The deflated balloon.
Because your instinct is probably to say, oh, the gallbladder is small, so it's not obstructed. It must be something else.
Correct. That's what a lot of people think.
Yeah.
But you have to think about the physics we just discussed. Why is it small?
Because it popped.
Exactly. The high-pressure fluid leaked out into the abdomen, the pressure equalized, and the balloon deflated.
That is incredibly counterintuitive. Finding a small, normal-looking organ in a really sick patient is actually the worst possible sign.
If you aren't actively looking for it, you will miss it.
So how do you confirm it? I mean, where did all that fluid go?
You have to look at the bare area.
The bare area. That sounds ominous.
It's a really unique anatomical quirk. Most of the gallbladder is covered by the peritoneum, which is the lining of the abdominal cavity.
Right.
But there is one specific spot where the gallbladder attaches directly to the liver. There is no peritoneum there. That's the bare area.
So if it leaks?
Well, if it leaks anywhere else, the fluid just spreads out into the whole belly and can be hard to track. But if it leaks near the bare area, or if the fluid tracks up into that space, it gets trapped. It can't diffuse away.
So if the radiologist sees a localized pocket of fluids specifically tucked in that space between the gallbladder and the liver...
That is a massive red flag for perforation.
That is such a specific high-value pearl. It's not just asking, is there fluid? It's asking, is there fluid in this specific anatomical tract?
Exactly. It's putting all the physical clues together.
This really ties it all back to the new paradigm. It's not just a checklist of symptoms. It feels much more like a narrative. You are building a case based on hard evidence.
That's the perfect way to put it. The old paradigm was totally binary. Stones, yes or no. Pain, yes or no.
But the new paradigm is a spectrum. We are measuring the degree of physiological failure.
Exactly. Is the pressure high? Look for the tensile fundus. Is the body panicking? Check the cystic artery velocity. Is the containment failing? Look at the echogenic fat. Is the structure collapsing? Check for mucosal loss.
And has the vessel already burst? Check the bare area.
You got it.
So we always end with the so what. Why does this matter for you, the listener? Whether you are a clinician or just someone interested in how modern medicine actually works.
It matters because precision saves lives. If we keep relying on the old ways, we are going to keep missing those 40% of gangrenous cases until they become fully septic. We are going to send diabetic patients home just because they didn't say ouch when we poked them.
And on the flip side of that, we might be cutting people open who don't actually need surgery.
Exactly. If we can use these objective metrics, like that 40 centimeters per second velocity threshold, we can be confident. We can skip the expensive CT scans. We can skip the HID scans that take hours and hours. We can make a definitive diagnosis right at the bedside, quickly and accurately.
It's a move towards confidence.
It's a move towards trusting the data over the feeling.
I think that's the big takeaway for me. Medicine often feels like this mystical art of intuition. But what we're seeing here with Laplace's law, fluid dynamics, acoustic impedance, is that the body is really a machine. And if you know how to read the gauges, the machine tells you exactly what is wrong.
That's entirely. The body is always talking. We just have to learn the language of the physics to actually understand it.
A language of velocity and tension. I really like that. Well, here is a final thought for everyone to chew on. We spent this whole time talking about how the Murphy sign is flawed because it relies on the patient's subjective experience of pain.
Right.
But this new paradigm relies on the body's objective distress signals. It makes you wonder, what other common diagnoses are we currently getting wrong simply because we are asking, how does it feel, instead of measuring how does it function?
Yeah, it is a very provocative question.
Mm-hmm.
And I suspect, as our imaging gets better and better, we're going to find out the answer is a lot of them.
Definitely something to keep you up at night. Well, thanks for joining us on this deep dive into the physics of the gallbladder.
Always a pleasure to be here.
We'll see you next time. Stay curious.